Welcome back to the deep dive. You know, as anesthesia specialists, we're always facing those high-stakes situations, and today we're really zeroing in on one that's close to home, especially for those of us working with obstetric patients.
Absolutely. We're talking about postpartum hemorrhage,
Mm.
BPH.
And to guide us through this deep dive,
That's right.
we're using a really comprehensive, up-to-date overview on PPH, updated just this past month, the September 2024.
Always got to stay current, right?
Absolutely, because we all know how critical this is for our patients.
It's life or death, really.
And this up-to-date document, it doesn't sugarcoat anything. It jumps right into it, calling PPH a leading cause of maternal mortality worldwide.
Yeah, it's a heavy reality check.
It is, and it highlights why we really need to be on top of our game. So, we all learned that classic definition of PPH.
Right. 500 milliliters of blood loss after a vaginal delivery.
Exactly.
Or 1,000 after a C-section.
But what this overview really stresses is that just going off those numbers, that estimated blood loss, it's just not enough.
Not even close.
Right. It's like it even uses the term,
Potentially lethal triad.
yes, hypotension, coagulopathy, acidosis. It's like this perfect storm that can catch us off guard.
And by the time we're seeing those big changes in lab values,
Yeah.
but traditional ones,
Right.
it might be too late to really turn things around.
Absolutely. And that's where anesthesia brains come in, right?
Yeah.
Because we're often the ones controlling fluids,
Yeah,
giving blood products, managing the hemodynamics in those critical moments.
right at the sharp end.
So being able to spot those early signs of hypovolemia
It's crucial.
before we even see that massive hemorrhage on the drapes, that's key.
Absolutely. And that's a huge theme in this document.
It really is.
It's like, look beyond just the EBL, the estimated blood loss.
Oh, yeah.
Pay attention to those subtle vital sign changes.
Those little things like the heart rate creeping up or maybe
Yeah.
a slight drop in blood pressure
Right. Even if it's still technically within the normal range on paper.
because those little changes, those subtle signs,
It can be the first clue,
they're like our early warning system, right? Before things really start to go downhill.
especially when you consider internal bleeding,
Oh, absolutely.
like into the abdomen or pelvis.
You might not even see it right away on the drapes.
Exactly.
So it's like that
Mhm.
saying, don't just stand there, notice something.
You got it.
And this is where communication with our OB colleagues, it's everything,
Oh,
right?
yeah. Teamwork makes the dream work.
Because we're the ones, minute by minute,
Right there.
monitoring those vital signs. If we see even a slight change, something that just seems a little bit off, we have to speak up.
Absolutely. Got to advocate for the patient.
It could be life-saving. And speaking of life-saving,
Mm-hmm.
this document really dives into something that I think a lot of us have been talking about, and that's the potential curveball with phenylephrine.
Oh, yeah. Phenylephrine. That's a tricky one.
Because it seems like it's keeping our patients stable, right?
Mm-hmm.
But it can actually mask how much blood loss they're really experiencing.
It's like a wolf in sheep's clothing, right?
Ex-
You see those numbers looking good on the monitor, but underneath.
Right, because it's a vasoconstrictor.
Exactly.
So it can really make that blood pressure look better than it actually is,
Yeah.
potentially leading to delays in those really important interventions.
And delays can be dangerous.
Absolutely. And we use phenylephrine all the time, especially during C-sections.
Right.
A lot of times we're the ones giving it.
It's true.
So we need to be extra vigilant, right? If we see that we're having to bump up those pressor requirements after the baby is delivered, that's a big red flag.
Absolutely. It's a sign that something else is going on.
We can't afford to get complacent, especially with something as commonly used as phenylephrine.
Couldn't agree more.
Now, beyond those early warning signs,
Yeah.
the overview really breaks down the different causes of postpartum hemorrhage, kind of like we all learned using that mnemonic, the 4 T's.
Tone, trauma, tissue, and thrombin.
Exactly.
The classics.
And while uterine atony, that tone part,
Right. The big one.
often gets a lot of the focus.
Rightfully so.
Right. This overview really emphasizes that trauma actually plays a much larger role in severe PPH cases than we might think.
Yeah. It's more common than we realize.
And by trauma, we're talking about injuries during delivery, right?
Exactly.
Lacerations, tears, and not just vaginal tears.
Right. We're talking cervical lacerations.
Oh, yeah.
Uterine rupture.
And these things can happen even if the delivery seems totally normal,
It can be really unpredictable.
especially if the patient has any risk factors, like a history of a previous C-section.
Exactly. Those previous scars can make things tricky.
And this ties into another point the document emphasizes.
Okay. What's that?
They're really advocating for us to move away from just relying on our eyes to estimate blood loss.
Oh, you mean visual estimation.
Yeah, because even seasoned professionals, we can be surprisingly inaccurate.
Our eyes can deceive us,
Right.
especially in the heat of the moment.
And that can lead to delays in recognizing how much blood loss is really happening.
Delays that can have huge consequences.
Huge consequences for our patients, exactly.
Yeah.
They're really pushing for something called,
Quantitative blood loss assessment.
yes, QBL.
Using those calibrated suction canisters, weighing sponges.
And not just for our high-risk cases either. They're recommending it for all births.
I like that approach.
Because why wouldn't we want the most accurate information possible, right?
Absolutely. Especially when it comes to something as critical as PPH.
It's like they say, hope for the best, but prepare for the worst.
Exactly.
And that means having the tools and systems in place to catch these issues early.
Regardless of how the delivery's going, right?
Exactly.
Even if everything seems smooth sailing, gotta be prepared.
And speaking of being prepared, let's talk about coagulopathy.
Oh, yeah. That's a big one.
The document actually calls it a silent escalator because those standard coagulation tests,
Right. Your PT, APTT.
even a normal fibrinogen level,
Right.
doesn't necessarily mean that coagulopathy isn't happening.
That's right. It can be lurking under the surface.
It's tricky, right?
Yeah.
Because those tests,
They can be slow.
they don't always reflect what's happening in real time.
Exactly. They're like a delayed snapshot.
And as anesthesia providers,
Mm-hmm.
this is something we have to be really mindful of, right?
Mm-hmm.
Because we're the ones managing those transfusions.
Right.
The clotting factor.
We're the blood product gurus.
So exactly. We can't just rely on those lab values that might not be giving us the full picture.
Right.
So what can we do then?
Well, the overview talks about keeping a close eye on those fibrinogen levels.
Fibrinogen.
Aiming for levels above 200 milligrams per deciliter,
200.
especially in those patients who we already know are at higher risk for PPH.
Gotcha.
And if those levels start to dip even a little, we need to be proactive.
Proactive. Okay.
Think about those therapies that directly replace fibrinogen.
Because sometimes just giving more blood is not enough.
It's like trying to put out a fire with a water gun.
Right.
Sometimes you need the big guns, like cryoprecipitate, for example.
Exactly. It's about having a whole strategy, not just a one-size-fits-all approach.
I like that. A personalized approach to blood management.
And I feel like this is where those point-of-care viscoelastic tests like TEG or ROTEM come in.
You're right. Those can be really helpful.
The overview mentions them as potentially useful, especially in these tricky situations with coagulopathy.
Makes sense. They give us a real-time look at the whole clotting cascade.
Yeah, it's not just one piece of the puzzle, it's the whole picture.
Yeah, exactly.
So we're not just seeing a snapshot in time, but it's like we're watching a movie of how well or not well the blood is clotting,
That's a great way to put it.
which can be really helpful when we're trying to decide, okay, what blood products do we need? How aggressively do we need to manage these clotting factors?
Absolutely. It helps us fine-tune our treatment.
It sounds amazing, but I'm guessing there's a but coming.
Well, yeah. As great as these viscoelastic tests are, they do require special equipment
Of course.
and training,
Right, which might not be available everywhere.
especially in smaller hospitals or like in the middle of the night. It's like having a fancy sports car. Sure, it's great to have, but you need the right roads and the right conditions to really get the most out of it.
That's a great analogy.
So even if we don't have those fancy tests at our disposal, there's still so much we can do.
Absolutely.
This overview really emphasizes those core principles.
Right.
Early recognition.
Early recognition. Okay.
Having a high index of suspicion.
High index of suspicion. Yep.
And of course, clear communication with the entire team.
Communication is key.
Always.
It's about being proactive, not reactive. Anticipating those potential problems before they become major crises.
Exactly, being one step ahead of the game.
And that actually brings us to another important point.
Okay, I'm listening.
This overview, it really challenges that common practice of automatically transferring unstable bleeding patients to the ICU.
Oh, interesting.
They make a really compelling case for why, in certain situations, keeping the patient in the OR might actually be the safest option.
That's a different way of looking at it.
Right, because we usually think,
ROR is for surgery.
right, and ICU is for critical care.
Exactly.
But they make the point that the OR is a much more controlled environment.
Which is so important in an emergency.
We've got the whole surgical team right there, immediate access to blood transfusions, everything we need to manage a surgical emergency.
It's true. Sometimes we forget how well equipped the OR is for those situations.
And as anesthesia providers, we're in a unique position to advocate for our patients, right? So if we think staying put is in the patient's best interest, We need to speak up.
Absolutely.
We need to be confident in our assessment
And be that voice for the patient.
and advocate for what we believe is the safest course of action.
Sometimes the best advocate is the one right there at the head of the bed, seeing those subtle changes and understanding what they could mean.
Exactly.
It's about connecting the dots and speaking up.
And this actually leads perfectly into the next part of this up-to-date overview.
Okay, what's next?
It's not just about managing that immediate crisis.
Right, yeah.
They also talk about the long-term impacts that PPH can have.
Oh, that's important. It's something we don't always think about in the thick of things.
It really is. But it's crucial for us as anesthesia providers to understand how the decisions we make during those critical moments, how those decisions can potentially impact the patient's life down the road.
It's a heavy thought, but it's true. We're not just managing the here and now, we're part of a much bigger picture.
Exactly. A continuum of care that extends way beyond that acute event. And one of the conditions the overview highlights is Sheehan syndrome.
Sheehan syndrome. Okay, remind me about that one.
So that's the one where if there's severe blood loss and hypotension during delivery, it can actually damage the pituitary gland.
The pituitary gland. Wow, that's serious.
Right, because the pituitary gland, that's like the master conductor of the endocrine system.
It controls so many important hormones.
Exactly. So damage to the pituitary gland, it can have really far-reaching consequences for the patient's health and well-being down the line.
Like what kind of consequences are we talking about?
Well, it can cause hormone deficiencies. That can affect everything from thyroid function, metabolism,
Wow.
fertility, milk production. It can be really debilitating.
It's a lot to think about.
It is, and it just highlights that even when we manage that acute blood loss successfully, there can be these lingering consequences
Right.
that can impact the patient's life for years to come.
It's a good reminder that our actions have long-term implications.
Exactly.
We have to be thinking about the big picture.
The overview also talks about Asherman syndrome, which is where scarring develops inside the uterus.
Asherman syndrome. I've heard of that one, but I'm a little fuzzy on the details.
And this can often be linked back to how PPH is managed, especially if there was a lot of manipulation or instrumentation inside the uterus.
Ah, I see. So it's like a potential complication of certain interventions.
Right. And Asherman syndrome can lead to some significant issues for the patient long term.
Like what kind of issues?
Well, think about menstrual irregularities,
Okay.
infertility, even complications in future pregnancies.
That's a lot for a patient to deal with.
It is, and it really emphasizes the importance of clear communication with our patients.
Absolutely.
We need to have those honest conversations about the potential risks
Right. Informed consent is key.
and the long-term implications of these interventions. And we need to make sure they have the right follow-up care.
Yeah, they need to know they're not alone in this.
To address any issues that might come up down the road, it's about empowering them with knowledge and support so they can be active participants in their own recovery.
Couldn't agree more.
Now, switching gears a bit.
Okay.
The overview really emphasizes the absolute importance of communication and teamwork during a PPH crisis.
Well, that seems pretty obvious, right?
It does, but it's amazing how quickly things can unravel when communication breaks down.
Especially in a high-pressure situation like that.
Exactly. We're talking clear, concise communication between everyone involved. The anesthesiologist, the obstetrician, the nurses, the blood bank.
Everyone's got to be on the same page.
Everyone has to be on the same page, and not just talking, but actively listening.
Right. And anticipating each other's needs.
Exactly.
Like a well-rehearsed orchestra.
It's like a perfectly choreographed dance.
Everyone knows their part.
Everyone knows their role.
Mm.
They're paying attention to their partner's cues.
Working in harmony.
And they're moving together seamlessly towards that common goal.
And that shared sense of purpose.
Right.
That feeling of being part of a well-oiled machine.
That's what can make all the difference when you're dealing with a life-threatening emergency like this.
It's true. When everyone's on the same page, miracles can happen.
And speaking of being prepared, the overview strongly recommends having a dedicated postpartum hemorrhage protocol in place.
Like a playbook for PPH.
Exactly.
Yeah.
Everyone knows their role, they've practiced the drills, and they're ready to act swiftly and decisively when the alarm bells go off.
No time for hesitation.
Right. And this isn't just about having a binder on a shelf somewhere.
Oh, no.
This is about regular simulations, debriefings,
Love those simulations.
and making sure everyone is comfortable with their responsibilities.
Practice makes perfect, as they say.
It's about creating a culture of preparedness, where we're not just hoping for the best, but actively preparing for that worst-case scenario.
Exactly.
Because, as we all know, in a crisis, seconds count.
Seconds can feel like minutes in those situations.
They even suggest having those dedicated PPH carts or kits.
Oh yeah, like our code cards.
Just like a code cart stocked with all the medications, equipment, blood products that we might need in a hurry.
Makes total sense. The last thing you want is to be scrambling for supplies when every second matters.
Exactly. It's about having those life-saving tools readily available, organized,
So we can focus on what's important, the patient.
so we can focus on what really matters, the patient.
Exactly.
Now, before we wrap up this part of our deep dive, there's one more thing I want to highlight.
Okay, what else is there?
And it's something that's particularly relevant to us as anesthesia providers.
I'm all ears.
Cell salvage.
Cell salvage? You mean like cell saver?
Yes, cell saver, where we collect and reinfuse the patient's own blood that's lost during surgery.
Ah, the autotransfusion.
Exactly. It's like giving the patient an autotransfusion, which has some big advantages over using donor blood.
Huge advantages. You avoid all those risks that come with donor blood.
Exactly. Things like transfusion reactions, infections.
Not to mention the logistics of getting those blood products ready in a real emergency.
Exactly.
Sometimes it feels like it takes forever.
And while we usually think of cell salvage for those high-risk C-sections, where we know there's a higher chance of blood loss.
Right, makes sense.
The overview mentions that there's a growing interest in using it for vaginal deliveries with severe hemorrhage, too,
Interesting.
even though it can be a little trickier in those situations logistically.
True, but it's definitely something to consider,
It is.
especially as we're seeing more and more cases of severe PPH.
And as anesthesia providers, we're often in a good position to advocate for cell salvage.
Right, to make sure it's available and ready to go if we need it.
Because again, when it comes to PPH, time is of the essence.
Time is everything.
Having that cell saver primed and ready to go could make all the difference.
Couldn't agree more. It's all about being prepared.
So to kind of sum up this part of our deep dive, we've covered a lot.
A lot of ground.
We talked about those crucial early warning signs, the importance of moving beyond just visual estimation and using that quantitative blood loss assessment,
Yeah.
and how those medications that we use all the time, like phenylephrine, can sometimes mask what's really going on.
Tricky phenylephrine.
We also talked about managing coagulopathy aggressively,
Being proactive.
understanding the potential long-term impacts that our decisions can have,
The big picture.
and of course that clear communication and teamwork within the care team.
Teamwork makes the dream work.
It really does. And we can't forget about those long-term implications of PPH, things like Sheehan syndrome, Asherman syndrome. These are things that we need to be aware of, that we need to discuss with our patients.
Absolutely. It's about providing well-rounded care. It goes beyond just stopping the bleeding. It's about seeing the whole patient, their journey beyond that acute event.
And I think this deep dive has really highlighted how important our role as anesthesia specialists is in these situations.
It really has. We're the ones who often see those subtle changes first.
We are, and we're making critical decisions about hemodynamics.
Blood products.
We're advocating for our patients when they might not be able to do it for themselves.
Yeah.
It's a big responsibility.
It is, but it's also an incredible privilege to be in a position to make such a difference in those moments, in those critical moments. And, knowledge is power. The more we know about PPH, the better equipped we are to handle these situations with confidence and compassion.
I love that. Confidence and compassion.
So to wrap things up, let's distill this down to some key takeaways for our fellow anesthesia specialists out there.
Okay, let's hear them.
First and foremost, trust your gut.
Right.
If something seems off, even just a little bit,
Don't ignore it.
speak up.
Speak up. Don't just rely on that estimated blood loss. Push for that quantitative assessment.
QBL for everyone,
Exactly. And don't be fooled by those seemingly stable vital signs,
especially if you're using a lot of pressors.
especially if you're using a lot of pressors. Be mindful of that phenylephrine, that sneaky little wolf in sheep's clothing.
Gyodai.
Think beyond just the immediate crisis. What are the potential long-term implications of the decisions that we're making?
Right, the long game.
Are there things we can do today to minimize the risk of complications for our patients down the road?
Prevention is key.
And perhaps most importantly, remember that you are not alone in this.
We're all in this together.
Communicate clearly with your team. Collaborate
Collaborate.
and advocate for your patients.
Dedicate like crazy.
You are their voice.
Yeah, protector.
Their champion in those vulnerable moments.
You said it.
This deep dive into postpartum hemorrhage has been anything but typical.
We went deep.
We really did. We've gone beyond the basics.
Beyond the basics.
We shed light on some critical nuances.
And challenged some long-held beliefs.
We did. And remember, Early recognition,
Early recognition.
prompt communication,
Can't emphasize that enough.
and a comprehensive understanding of PPH management are paramount.
They are essential.
You are the guardian of the patient's well-being, and this knowledge empowers you to make informed decisions.
Informed decisions.
Advocate for your patients.
Advocate, advocate, advocate.
And potentially make a life-saving difference.
That's what it's all about.
That's it for this deep dive into postpartum hemorrhage. Until next time, keep asking those questions, keep learning, and keep diving deep.
See you next time.